Thank you, Mr. Chairman. Just to confirm, Mr. Griffin, you said there were 69 cases where you are now following up to review possible criminal implications.
There are 69 separate facilities beyond Phoenix that we have sent rapid response teams to as allegations have come in to us.
Specifically criminal allegations?
No, first of all, they're just allegations.
Sure, no,
we send criminal investigators there to take sworn testimony and try and get to the ground truth. But in some instances, sure, you know, you're only as good as your source, right?
Sure, no, I understand, and,
right,
and allegations have to be vetted out.
Right.
But
yes, sir.
You use the term criminal, and I wanted to confirm.
That's right.
Okay. This is different, though, Mr. Makovsky, though, from the follow-up visits that are required of some of the institutions based on your audit, correct?
That is correct.
Totally separate, okay. The timing, and I know it's come up for additional information on those follow-up visits, is it weeks or months? I realize
weeks, sir.
Weeks.
Weeks. We'll be working with the Office of the Inspector General this week, putting together a plan, which we've already started, and then it'll just be a matter of weeks. I agree that we need to make sure that veterans understand that their care is still quality care, and that what we've identified here is questions of practice integrity.
Great. Mr. Makovsky, I want to thank you for your candor this evening. You know, Congress often gets frustrated with trying to get information from this administration. You are demonstrating an exception to that tonight, and I want to compliment you for your honesty and your references to some of the frank problems within the VA. You spoke about non-VA care in your terms being now the veteran's choice, and this is one of the issues that I've raised repeatedly now. I think within the current system, the ability to get to non-VA care sometimes is obstructed by a process where a patient has to go to the very same medical staff that said they didn't need it. Has that changed? Your term now, patient's choice, has that changed?
It is changing, sir. It's going to take time. In conjunction with accelerating care, we provided training to roughly 1,900 of our facility and regional staff. That was over a period of about 6 days. In addition to that, we've since offered and delivered training to about 2,700 staff for appropriate use of the scheduling package and how to manage no-shows, how to schedule appointments, et cetera. It's going to take a lot of that. It's going to take a lot of communication, constant communication, and then frankly monitoring. If we see delays and we don't see use of non-VA medical care, it's incumbent on us in Washington and at the network and at the facility to ask the question, why?
Right. But has there been a change in the same medical staff that initially said no having to sign off on now saying yes?
The change is the degree of vigilance that we have in the communication of our objective that the veteran must be offered a choice.
Okay. Along those lines of analogous to non-VA care, I think each of you would agree tonight you've referred to it as a problem within management, at least places of management throughout the system, as opposed to the staff and some of the doctors that the veterans say provide great care. Currently in some VA facilities, private sector healthcare systems provide management, different than just seeing a non-VA physician. Is there value in expanding the use of regional healthcare system providers to provide the management? So I understand from a number of the veterans I speak to, they want to stay within the VA system. They like their VA hospital. So the idea that some have suggested of just feeing everybody out or using a voucher program is not something that I believe the veterans community would really embrace. But can we expand the use of private sector healthcare systems to provide management for facilities? What would your thoughts be on that?
In some cases, we do use that. As you know, with contract community-based outpatient clinics, we do have some partners in the private sector that help us manage some of our outpatient clinics.
But those are really smaller facilities, right? What about the very large hospitals where peer-to-peer, I mean, and let's be honest, it's not a criticism, there simply cannot be the private sector efficiencies in a large VA hospital currently. Is there value in looking at larger facilities and saying, can we provide private sector management?
Sure. I mean, I think we can look at it. The one thing that I would tell you, if this crisis has taught me anything, it's to question everything and the intent behind everything.
Has there ever been a comparative study of performance based on management from private sector?
Periodically, we do. The one thing that I would just just one moment of concern. A lot of our measure of the private sector efficiency is a revenue-based metric, which is to generate revenue. So I would say that, other agencies, Medicare and others, have had some issues with that. So our version of productivity, I would just ask us to have some measure of skepticism in the interpretation of that productivity data. It is tied to revenue.
I want to thank you again. I really do appreciate your candor, and I will tell you, 2 weeks ago, many of us were asking for urgency. I think we've heard that from you tonight. I know the acting secretary has demonstrated his approach as one of urgency as well, so thank you very much. Mr. Chairman, I yield back.
Thank you, Mr. Jolly.